about this, right? But let's get down to more of the nitty-gritty, okay? So when you look at dobutamine, what is this drug used for? Why are you starting it, okay? And then, what is the expected results? How is your patient going to look if you have achieved what you started it for, okay? What do you expect to happen? Okay, and then what type of patient, we've already talked about this, right, would this drug benefit? So take a couple minutes, and then let's talk about it. Just so you know, class won't be any different. Class will still be the same. I'll still be the same person that I'm up here, because obviously why would I be any different? But just know that people may come in to observe and awkwardly sit right there in the front. Because there's no back. No back for them to go. What'd you say? Yes, perfect.
So
Alex, you and Lacey, you have two seats. You can raise your hand and be like, sit here, sit with us.
I might start speaking in like a British accent. It won't go.
I would love that. I'm here for the accents. I'm here for it. My boyfriend, he does that, and yet he always sounds like an Australian. Whatever accent he's doing, could be German, Italian, always sounds like an Australian. So if you'd like to do that and have some, I'm here for it. Let's do it.
I mean, if I can't say anything stupid, I might as well say.
So I mean, I'm here for it. It's just like, anybody watch Friends? Any Friends people? It's like when Ross develops his English accent, right? You guys, if you don't know Friends, you have to watch it. It's so funny. You guys, please. I've done so many references. The Friends, oh my gosh. I think you can still watch it on HBO Max. Highly recommend. Okay, so let's talk about dobutamine. Why are we starting it? First of all, what is this drug used for? I see it right here. La la la. Used for contractility, positive inotrope. I love it. I love it. Perfect. Okay, so we know that this is usually the first line inotrope. Okay, this is going to help the heart contract more effectively. Okay. It certainly helps our stroke volume. We know that, right? It helps the heart contract more effectively. Now, the key, and I think someone put that, is that it also helps to lessen afterload. So it's like a twofer, helps the heart contract more effectively, okay? And it lessens your afterload a little bit, okay? What is afterload? If you had to pick one word to describe what afterload is, what is it? Resistance, okay? So, how does that make sense? Well, it's going to help our contractility pump more effectively, and then it reduces what it needs to overcome downstream. Okay? So, that being said, if we know that it's going to decrease afterload, okay? What do we need to make sure that we're monitoring if we know that it can decrease afterload? What would we maybe need to anticipate? Blood pressure, yes, absolutely. It might be a little bit, or it might be a lot. If your patient is already hypovolemic, it could cause a significant drop in blood pressure, okay? It doesn't mean that you don't start it, right? It just is something to be aware of, okay? It's something to be aware of. You may need to add another drug or fluid to help mitigate that drop in blood pressure, okay? Does that make sense? So it's kind of a twofer. It's a positive inotrope. It helps the heart contract more effectively, but we know that it also reduces afterload. And in a hypovolemic state, it can really cause some profound hypotension, okay? It is contraindicated in someone with a sulfite allergy. So if you have someone that's allergic to sulfite, you can't give it. It's weight-based, okay? And then I love it. I love that people have used this. Cardiogenic shock, love it. CHF patient. MI patient, sure, heart failure. If the pump is not working effectively, I love it. So, now let's get to the nitty-gritty of this. How do I know it worked? How do I know it worked? Okay, so cardiac output. Let's say you had a CCO monitor. You love hemodynamics just like me, yay. We have a Swan that's giving me continuous cardiac output and cardiac index readings. My patient comes in, CHF exacerbation, it's kind of turned into cardiogenic shock. Cardiac output is 2. Okay, I start dobutamine, what would I anticipate it to be? What do you think it would go up to? What? Hopefully higher, right? Hopefully 4, okay? Know that dobutamine is oftentimes not something you titrate, okay? It can be a titratable drug, but oftentimes at the bedside, I'm talking my hospital, I'm talking my bedside, okay? The patient or the physician will give you a fixed rate, okay? They'll give you a fixed rate. If it is titratable, you better have a CCO monitor, a continuous cardiac output monitor, and you would be titrating it not to cardiac output, but to cardiac index. Cardiac index is more specific to the patient because it's based on their BSA, body surface area, okay? So again, if you're titrating it, oftentimes you're titrating it to a cardiac index. Please, 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 please do not titrate it to a blood pressure. That is absolutely wrong, okay? You are titrating it to cardiac index. Why? Because it's a positive inotrope. It's helping the heart to pump more effectively, okay? So let's say you don't have a Swan. You don't have cardiac output. You don't have a CI. You don't have cardiac index. How would I know that this is working? How would I know that the dobutamine is working? The physician ordered a fixed rate at 5. How do I know? How would the patient present?
The signs of good cardiac output.
Great. Okay. I see Alex is doing this. What is this? Cap refill. So they would look good, right? So your skin would improve. Skin, they would not look pale anymore. They would look pink or whatever is normal for the ethnicity, right? The cap refill would be great. They wouldn't be clammy or diaphoretic. Okay. What else? What else might be good? What? Okay, sure, absolutely. So if you were to do a gas, that might increase. I love it. What else? Yes, absolutely. Urine output would increase 100%. What if the patient was altered? They come in and their cardiac output was 2. Index was 1.1. And they came in altered, meaning they were confused. Their level of consciousness was not good. They were lethargic, /obtunded, hard to arouse because their brain was not getting the perfusion they needed because their cardiac output was really, really low. So if I started dobutamine, what would I anticipate my patient to be now? ANO! Yes, not confused. ANO times 4. Not lethargic, awake, alert. Okay? What do you think my map would be if I had good cardiac output, if I fixed it?
65.
It would hopefully improve, right? It would hopefully improve.
With the risk of the blood pressure lowering with it,
Sure.
is it still gonna be good? Like
So-
that, or
It depends, right? So hopefully if you saw, again, you guys, I get it. You want the cookbook. You want A plus B equals C. That's not how it is. So if you had someone that was hypertensive, and you started dobutamine, now you have a better blood pressure, you've increased your cardiac output, your MAP should be fine, okay? If you have someone in shock, meaning that they're going to be hypotensive, oftentimes you're going to start something as an adjunct to the dobutamine, okay? So theoretically, if your cardiac output is better, right, you may also have to start a vasopressor, but that combination of things should increase your MAP. Does that make sense? Okay. So does this make sense? So on the test, for example, I'm gonna say this patient had, dobutamine, they came in for a CHF exacerbation. How do I know that dobutamine is working? Okay, you're going to have to pick the option that says your skin is better, your kidneys are looking better, you're making urine. Okay, my map is better. I'm not confused. Does that make sense? So those are the types of questions you can anticipate. There's 2 different modules. There's a hemodynamic one, Nearpod, that I'll publish today. There's another pharm one that has practice questions that are like this, that can prepare you, okay? And then also the ones, lots of resources and help, the ones at the very bottom of quizzes can also have practice ones, okay, that I advise you guys to do. Questions about dobutamine? No? Okay, let's move on. All right, so corticosteroids. Hopefully you guys have learned about corticosteroids in the past. We're bringing it back, right? Yay for us, we love corticosteroids. So what would you include in the teaching for a patient that's on corticosteroids? Usually it's, corticosteroids, it could be long-term or short-term, okay? But what kinds of things do you want to teach your patient? Let's say especially long-term. So take a couple minutes, write it down, and then let's talk about it. You will see the use of corticosteroids when we get to neuro. Okay, that's laying the foundation. You can also see them when we talk about septic shock. Okay. Sometimes for spinal injuries, sometimes not. But certainly for neuro. All right, let's talk about it. It's so fun that I can make comments. I love that. Okay, so what do corticosteroids cause? So the number one thing that people need to be aware of is hyperglycemia, right? They can raise someone's blood sugar. I don't know how many times I've been giving someone corticosteroids, right? I go in to check their blood sugar. These are the people that are awake and talking to me, right? And I was like, oh gosh, your blood sugar is 190. And they're like, what? And I was like, yeah, I'm gonna have to give you a unit of insulin. And they're like, what? And they're like, I'm not a diabetic. I don't need insulin. I don't take that at home. Why do I need that, right? So again, it's having to explain. It's having to teach your patient, hey, I'm so sorry, you're on corticosteroids, you are getting dexamethasone to help your lungs, or whatever reason why they're getting it, okay? Or you have a brain tumor and you're getting dexamethasone for that to lessen the swelling, right? So it raises your blood sugar. In the ICU, we have a tight glycemic control. We don't like people above 150. So anybody above that, you will get sliding scale. You probably won't go home on insulin. Please don't be freaked out. It does not automatically mean you're diabetic, okay? So just know that when someone's on corticosteroids, you need to make sure that you are controlling their blood sugar. Now, taking that in the same line of thinking, what happens when you have a diabetic on corticosteroids? What do you think? Okay, requires more insulin. What other things could happen? What do you think? What? Okay, sick more easily. Sure, absolutely. So just know that when someone's diabetic and they're on corticosteroids, all of the things that you're at risk for developing goes up. Okay? My grandpa, he was a type 2 diabetic, and he had to have corticosteroids when he went in for his PCI because he was allergic to the dye. He was allergic to iodine. So, sadly, all his blood sugars went sky high, okay? I don't really know why they didn't start him on an insulin drip, but I regret not advocating for that looking back on it. But he told me that he couldn't see very well. He said that his eyesight was starting to affect it because his sugars were so high, okay? His neuropathy in his hands and his feet started to worsen, okay? So again, know that all of these effects that we're talking about, diabetics, it's going to affect them worse, okay? So you said they can get sick, right, more easily. It's an immunosuppression, right? So if someone's on long-term corticosteroids, maybe encourage wearing a mask, right? Or, what do you think? Washing hands, right? Hand hygiene is super important to prevent. Maybe they got invited to go to their grandkid's party, but the grandkid has RSV. Do you think that's someone that they need to go, maybe they need to stay away, right? So educating them about the risks, okay? They have, a wound on their leg. Sad. Do you think that's going to heal adequately if they're on high-dose corticosteroids, or corticosteroids in general? Do you think the leg ulcer is going to heal quickly? Oops. No. It's going to impair wound healing, okay? What do you think it's going to do to my WBCs? Our white blood cells. What do you think?
Decrease.
It could decrease or increase, okay? Know that it can increase them, okay? It increases the risk for infection, but it also can falsely increase your WBCs, okay? I've had that where I forgot my patient was on corticosteroids and I, sent a CBC and I saw the WBCs and I was like, whoa, why are they 20? What happened? They're not showing signs of infection while they're on corticosteroids. So just know that that can happen, okay? The other thing is that your electrolytes gets messed up. What electrolyte in general? Do you guys know? What happens, especially with long-term use of corticosteroids? What electrolytes get messed up? I don't think so. Try again. Sodium. Yes. Does that go high or low? Goes up. So sodium can go up because you have increased swelling, okay? You have fluid retention. And then low potassium, okay? So low potassium, increased sodium, increased swelling, fluid retention. That can happen with corticosteroids. GI irritation and protein wasting. All of those things are things that you need to be teaching your patients about and aware of, okay? Because again, you need to be able to understand and speak to it. Why is my potassium 3? Well, they're on corticosteroids. Why is my sodium 50? Well, they're on corticosteroids, okay? Wow, they're really edematous. What's going on? They're on corticosteroids. Maybe we need a diuretic, okay? But not diuretic that's gonna drop their K even more because they're hypokalemic really, okay? So maybe a potassium sparing one, or replace your K before you give your Lasix. Does that make sense? Questions about this? Okay, so let's talk about antiarrhythmic drugs, okay? So you were exposed to a couple antiarrhythmic drugs. Let's name a couple, and then what do I expect the result to be? Like, why did I start it in the first place? What's going on with my patient? And then what are some nursing considerations that you have for them? Can I erase this, you guys? Can I erase this? Yeah? Okay.
Like this stuff, but you know what's not gonna break. My brain's already.
This eraser stuff.
It's just not up. That's pretty great, Kelsey. Stick up, that's not compute.
Oh, week is okay.
Okay, so let's talk about this. So antiarrhythmic drugs, break it down, right? Make it make sense. I'm all about that, okay? I know pharmacology is hard, but you guys got this. So when we look at the class, quote unquote, of antiarrhythmic drugs, right? So no, right? So antiarrhythmia. So what is the drug trying to do? It's trying to prevent or fix an arrhythmia, an abnormal rhythm, right? Okay, so we're looking at these drugs. You guys had picked some great ones. I love it, okay? So my personal favorite that I just love, I know it's weird to have a personal favorite of an antiarrhythmic drug, is amiodarone. Okay, amiodarone. Don't worry, I couldn't say that for years. You'll be able to say it eventually, okay? Amiodarone. And it took me a long time to be able to say it.
Amiodarone?
Yep, perfect, good job. Yep, amiodarone, yep. So, you know, the easy thing to just say is amio. Can we start some amio, right? People will know what that is, but the full way how to say it is amiodarone, okay? So, why are we starting amiodarone? What kind of arrhythmia are you encountering? Okay? What? AFib, okay, perfect. I thought I heard something else, but AFib, yes. Oftentimes, it's going to be unstable AFib, okay, unstable AFib, or VTAC, okay, ventricular tachycardia. So unstable AFib or VTAC. This becomes very important, you guys, next week. Okay, next week when we talk about cardiac rhythms, I will provide you with a resource that will help teach you what they are, but we're at the application stage next week, okay? So I'm going to show you a rhythm, a VTAC, and I'm going to say, what are you going to do about it? Okay? So you'll have to be able to recognize what that rhythm is, VTAC, and then what are you going to do about it? With a pulse, not a pulse. Okay? We'll go over it, don't worry, but we're at the application stage, okay? So you need to be able to understand what kind of rhythm. Same thing with these drugs, okay? These are not going away, you will see them, okay? So amiodarone, unstable AFib or VTAC, okay? And then hopefully it's going to convert, right? It's going to convert that rhythm possibly back to sinus rhythm, hopefully, okay? Just so you know, for your personal information, I'm not going to ask you this, but know that oftentimes you start with 150 milligram bolus, okay? There's a protocol concerning the amiodarone. It's in the MAR, you'll be able to see it. You give 150 milligram bolus, and then you're at 1 milligram per minute for 6 hours, and then 18, right? 6 plus 18 is 24, is that right? Yeah. Is 0.5. Now, know that the physician can say, no, I want to leave it up. No, I want to leave it at 1. We've had lots of rhythm issues, so I want to leave it at 1. It's up to the physician to order what they want, but know that's usually the protocol, okay? With amiodarone, it's something to be note. It has a very long half-life. Anybody know what it is? 53 days. Yes, very, very long half-life. So you give a little bit, lasts a long time, okay? Now, you should not be giving amiodarone to pregnant or lactating patients, okay? You need to administer it with a filter. And what kind of vital signs do you need to be assessing with this?
Blood pressure, cardiac rhythm.
Heart rate and blood pressure and cardiac rhythm. I love it. All of those things. Because we know that it can affect someone's blood pressure. We're hoping that it can convert someone out of whatever abnormal rhythm they're in, whether it's VTAC or unstable AFib, okay? But both of those things you need to be anticipating. Now, we need to understand, with amiodarone, there's two different routes for two different situations, okay? Amiodarone can be an IV push, okay? Usually that's when someone is dead. You're giving it for VTAC, okay? 300 milligrams. Or they are alive, but they're unstable with AFib, it's gonna be the continuous infusion, okay? Half-life of 53 days lasts for both. Okay, questions about that? So the expected result would be what? What do you think? Huh? Hopefully sinus, yeah, sinus rhythm. Hopefully it's gonna convert the rhythm, absolutely, okay? Perfect. Okay, next one that we'll talk about, I see adenosine, but we have our own fabulous slide for that because there's much to talk about. Diltiazem, also a great one. What is diltiazem? If you had to class it, what kind of antiarrhythmic is it? Calcium channel blocker. Excellent. Good job. Okay, so why would I give diltiazem? What type of patient do you anticipate starting diltiazem on?
AFib RVR.
Okay, AFib RVR. Alex, what does RVR mean?
It's a rapid ventricular rate.
Okay, so tell me more.
So the heart is, normally the heart beats off of the SA node at a rate of 60 to 100.
Sure.
When someone is an RVR, basically the SA node is not firing normal, it's firing from lower from the AV node,
Okay.
and it's just going way too fast.
Okay, perfect. So keywords. I love that you went deeper. I love that. But all I need you to understand with a rapid ventricular rate is it's going to be too fast. Okay? It's going to be above 100. Okay? But probably more so than that. 120s, 130s, 140s, 160s. Okay? So again, make it make sense. Break it down. Rapid ventricular rate. So a fast rate. So you're absolutely right. AFib with RVR. Okay, that's something that you would start diltiazem. Okay, so with knowing that it's a calcium channel blocker, with knowing the mechanism, what vital sign am I going to be particularly interested in?
Heart
The heart, but what else?
blood pressure.
Blood pressure, yes. Okay, a calcium channel blocker by nature is an antihypertensive. Okay, it's going to lower your blood pressure. So let's say that your patient came in, AFib with RVR, they're AFibing at 150 to 180. It's pretty high, right? But their blood pressure is like 90 over 60, MAP of 55. Is diltiazem an appropriate drip to start? No. Okay, why? Because it's going to drop their blood pressure, absolutely. So these types of patients, what you need to be anticipating is that someone with high blood pressure is going to be the candidate for diltiazem. So again, similar situation, right? I know, you guys want the cookbook, you want the recipe, but you have to look at your patient as a whole and says, does this drug make sense for this particular patient? If I start this, what's going to happen? What can I expect? So yeah, I'm hopeful that it's going to decrease the rate. It is used for rate control, but I need to also be anticipating that it's going to drop my blood pressure. Okay, it's going to drop my patient's blood pressure. I know, I always do that, where it's like me, the patient, whatever. Okay, so know that the antidote to diltiazem is calcium. Okay, calcium channel blocker, calcium. Okay, so it's used for rate control when you have AFib, RVR, or A flutter. When you have a high rate of A flutter as well. And again, the key is to monitor that blood pressure. Okay, similar to amiodarone, but again, I would only start diltiazem if I have a solid blood pressure, a high one. Okay, does that make sense? Questions? No? Good? Yes?
So it's used for AFib and VTAC too?
Not VTAC. Just AFib with RBR or A-flutter. Because it's not gonna convert anything. It's just going to help with rate control. Okay?
Slow things down a little bit.
Exactly. Slow things down a bit. Exactly. Good. Okay, and then we have esmolol, which we can kind of count in this. I'm fine with that. So esmolol is what type of drug?
So a beta blocker.
Beta blocker, exactly, perfect. So what type of patient, what type of rhythm would you anticipate starting a beta blocker on? Sinus tachycardia, exactly. Be careful, guys. Be careful, okay? So biggest thing, right? One of the biggest things I want you to remember from my class is figure out why your patient is tachycardic. Why, okay? Years ago, when I worked in Flag, we had a new trauma nurse practitioner, okay? And I called him and I said, hey, I want to let you know that my patient's really tachycardic, 140s, 150s, okay? And he's like, okay, you want to start a beta blocker? And I was like, well, I mean, sure, that's going to fix the problem. It's going to slow everything down, but I don't know, I feel like there's more to the story, okay? And I said, could I send some labs? Now, this is a trauma patient. They came in as a trauma, okay? And he was like, yeah, sure, that's fine. Very easygoing. Whenever I asked for something, he usually gave it to me, okay? And I said, okay, I'm going to send a CBC and like a CMP, complete metabolic panel, just to see where we're at, okay? So, goes to show, right, he was still bleeding somewhere, H&H was low. The reason why he was tachycardic, H&H came back like 5 and like 19, okay? He was tachycardic because he was hypovolemic, he was bleeding somewhere, okay? Now, if I would have just given the beta blocker, I 100% would have made things, I would have fixed it, right? I would have slowed him down, it would have been great, but I wouldn't have fixed the cause, right? So when you're giving a beta blocker, make sure you understand why your patient's tachycardic, okay? Sometimes you need it. Sometimes you need it for whatever's going on, okay? Someone has an MI, you want to protect them from that excessive myocardial ischemia. You don't want to cause the myocardial oxygen demand to go up, right? You're trying to preserve that. So you might need to block them down, okay? But be careful, you don't want to block them down and decrease that cardiac output because it is a negative inotrope, okay? Just know that esmolol is one of those things that you need to understand the full picture before you start the beta blocker, okay? And then same situation, guys, it's also gonna lower your blood pressure. So make sure you're aware of that, okay? Make sure you're aware of it. Questions about what we talked about? Amio, diltiazem, and esmolol. We'll get to adenosine, don't worry. No? Good? Okay. Okay. So, adenosine. Now, the thing I want you to know is that this is an IV push only drug. I should have brought in my 3A stopcock, but I forgot. I'll bring it in. Don't worry, I have a list that's going in my head of things I need to bring in to show you. So what kind of patient needs adenosine? What nursing considerations do you need to be thinking about, and what is the expected result? Isn't this pretty? I just love it. I'm like obsessed with this background. Strong work. I don't know why I'm not approving this, but whatever. Okay, so this is an example. You guys are finished this. This is how you should be thinking about this, right? So you have your drugs here. What are you using it for? And then what is the expected result, right? So amio, unstable AFib or VTAC, hopefully convert the rhythm. Back to science. DILT, AFib RVR with A flutter, what's my expected result? Rate control, okay? Esmolol, sinus tach, what do I expect? Hopefully your heart rate will go down, okay? This doesn't include your nursing considerations or things like that, but that is an example of what you need to be thinking, okay? So adenosine, why would we use adenosine? Your specificness is fabulous, you guys. I love that you put Wolff, Parkinson, White syndrome. It's perfect. What you guys need to know, we're not learning WBW, thank God. But what I need you to know is that adenosine is used for supraventricular, okay, tachycardia, okay, SVT, okay. Supra is above 150, okay, tachycardia above 150. So adenosine, right, there's lots of A's. You're like, Professor Bloor, what are you trying to do? You're trying to confuse me. No, I'm not. So adenosine, how I remember it, right, how everyone should remember it, is oh my god, all these S's. You're trying to slow down the heart rate, okay? SVT, super fast, okay, above 150. Handwriting's getting messier and messier, you guys. So SVT, adenosine, focus on the S. You want to slow it down, okay? So it's IV push only. If you mark that this is a drip on the test, you will lose that point, okay? IV push only. This is a drug with a very short half-life, okay? Very short half-life. Oftentimes the dosage, again, I'm just telling for your knowledge so it goes in your brain. You don't have to, there's no test question about this. But oftentimes it's a rapid IV push, 6 milligrams. Hopefully it works. If not, you can do 12 and 12 after that. You're trying to slow the heart rate down, okay? Now, please know that adenosine causes a transient asystole. Okay, what do I mean by that? The heart can stop, okay? So this is not something that you push willy-nilly by yourself, okay? What do I mean by that? You invite people to the adenosine party. Who are those people? Your physician, okay? You never push adenosine by yourself. You have a physician at the bedside, okay? Standing there watching, okay? You invite your charge nurse to the party, okay? Why? Because you need a friend. You need a friend. You're gonna set it up in a 3-way stop cough. I'll bring it in so you can see it. Why? Because you need to push it fast. There's no time for aseptic technique of you disconnecting the syringe, attaching a flush. No. By then, it's gone. The drug is gone. It doesn't work anymore, okay? It's super, super quick. Now, if you had a choice between a peripheral line and a central line, where should you push it? Central. Why? Right to the heart. Right to the heart. So push it with your friend, okay? You should put pads on your patient. You should have them hooked up to the defibrillator, okay? Is it rare to have the heart stop? Absolutely. Does it happen? You betcha, okay? So you need to be prepared for that. If your patient is awake and talking to you, you need to alert them that this is going to feel awful. They might have intense chest pain. They might feel very flushed. They're gonna be nauseous, okay? Let them know it sucks, okay? Please don't tell them they're going to die or they could die, okay? But know that it's going to be uncomfortable. You're gonna be with them all the steps of the way, but know that it's going to be uncomfortable, okay? So here's this fabulous video. I just love this, it's so great.
So in the soft chalk, it said esmolol and adenosine are given for SVT?
Some people is not perfect. Some people.
Yeah, you can use esmolol to close it down to slow it down. But this is more, I think you use more adenosine when you're in SVT, especially like higher rates. But you can use esmolol. It's going to slow it down, irregardless.
Start with the medication. I want to try to see if the vagal maneuvers do work. Some people it works. If it works, then for you, you learn how to take care of this yourself if this ever happens.
Okay.
Vagal maneuvers means like when you go to the bathroom and poop and you're very constipated, you have to push really hard. What that does is it slows your heart rate down. So if you do that for me, you're gonna take a deep
I
breath.
did that ambulance.
It didn't work? Okay. Well, let's try it again. Just for kids. Once you get trained. I'm gonna take a deep breath, and then imagine you push my arm out. Push my arm out. Push, 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 push. Push in there.
Bless me on the way.
Okay.
Okay, it sounds rough, right? Okay, so she's an SVT, right? 180s, 190s, whatever. He's asking her to do something less invasive, right? When we got to SVT next week, this is what you're gonna be answering. So he's saying, I want you to try to vagal. I want you to try to slow it down yourself. Okay, she said bear down. I can guarantee most people, they try, they don't really quite understand what that means to have a bowel movement. I know that you're like, what are you talking about? People have bowel movements all the time. But in the moment to bear down, sometimes that's hard for people. So what I like to do is I take a 5cc or 10cc syringe and I have them try to blow the plunger out the back. So that action, they can understand it a little bit more, especially someone maybe that's geriatric, where you're telling them to bear down and they're like, I'm doing it, and they're not doing that, okay? So that's she's awake, right? She's talking, you can hear her sweet little old voice, right? So what would you do if someone is an SVT and they want to try a less invasive method instead of giving medication to someone that's intubated? What do you think? How can you make someone try to vagal, right? Lower their heart rate if they're intubated. What do you think? Anybody?
I mean, there's a carotid massage.
Okay, so absolutely, you're totally right, Alex. That is not within our scope of practice to do. Nurses are not allowed to do that. Great thinking. Physicians will try to do it, absolutely. But please, nurses, please don't do that. That is not within your scope of practice to do. Great thinking though. They have tried to do that. What else? Someone's intubated. What can you do? What? What do you think? What about suction? Suction or cough, right? Anything that causes the interaction of your PNS, parasympathetic system, okay? So vagal, so anything to make someone vagal, cough, suction, make them cough, suction them, you can try to do that, okay? Most of the time it doesn't work. Yeah.
I used to have SVT when I was a kid.
Did you?
The doctor told my mom to try to scare me or like dunk my head in a bucket of ice.
Oh wow, okay.
Or like they're like plug all your orifices and like bear down.
Bear down. Yep, totally.
There have been a few times where we've had a patient where we threw a bucket of ice at him and
Wow.
it worked.
I think it's the
Really?
shock. It like shocks your body.
The shock of the
into,
cold
like-
water on your face
Sure,
will convert you.
sure, wow.
And if that doesn't work, it ends it.
Wow. Where are you getting the ice from?
On the
Well, I mean, I'm on an ambulance, we're at their house, grab it out of their freezer.
Wow. Sure, I'm down for that. Anything that can work. I mean, I'll have to ask Kevin if he's done that before. I think that's great. Perfect. I mean, anything less invasive to get them out of
Throw it in
it.
the kitchen sink, fill it up with water, dunk their face real quick. If that doesn't work, then
Wow. Is this recent or years ago?
last time I did that was about a year and a half ago, but adenosine, I love using adenosine.
Sure. Adenosine's the winner. Absolutely. Okay. So this is, okay, so I'm just gonna fast forward. This poor lady is coughing. The very down didn't work.
Did they also do the massage in the neck?
Okay, this is what he's talking about.
So
Try
this
the
what
massage.
we do is, this is things that I'd like to teach anyway, because if you're,
La. Okay, she hit 205, 202.
we're gonna start
So,
with 6 milligrams
reason
per
we
day.
do this is because
If you're gonna feel really sick initially, the medicine kind of responds.
So see, he's telling her, hey, you're gonna feel really sick. I just need you to know that, okay? So they're doing 6 milligrams of
Since your
adenosine
clock,
first.
and until the clock starts again, you feel like you're passing out. So it's a lot of
Passing
people
out.
complain, it's almost like terrible feeling.
They had already timed out. That way.
So the most important thing about the push is that we do the flush.
They did the flush and ambulance.
Alright, sweetie.
I think on feet.
we're pushing right now, 11:21. And we raise the arm up to make it go faster. This medicine only lasts in your
Maybe do that,
system
maybe
a few
not.
seconds, so if we don't push it hard enough, it just doesn't do anything. Often we have to go to double that dose to make sure enough medicine gets into you. And there we go.
See how that she's slowing down?
She's going right back to it.
So there's always that moment, right, where you see the ECG start to slow and you're like, oh, is it gonna start back up again, right? That's the transient asystole that can happen. You really hope that it does. She's starting back up. Now, looking at this monitor, right, I'm sure they're probably in the ED, that would be my guess, right? Doctor seems to be educating her on stuff. The nurse said 6 milligrams. They talked about the rapid bolus, the eating of flesh right after because it's a short half-life, right? What vital signs are we missing here? What else would you like? Blood pressure, yeah. How about oxygen? I mean, I feel like this is like not a great pleth, right? The waveform kind of sucks. Plus there's no number here. And then where is my blood pressure? How about get some blood pressure while you're doing this, right? So again, if she's in the 190s, 180s to 200s, we absolutely need to be able to check her blood pressure. That's something that they're a vital sign they're missing, okay?
Is it usually down?
It depends. It totally depends. Absolutely. So if the adenosine did not work and then they become unstable, where they're hypotensive, then, which we'll talk about, you're going to sync cardioverter them.
Well, because there's not enough time to even fill
And it's not working.
when it's.
Right, exactly. You're absolutely right. Yes, exactly. If you look at your cardiac output rhythm, there's no filling happening. Absolutely. At a rate of 205, absolutely not. So you guys can watch the rest of it, but eventually she does slow down, okay? But this is exactly what you'll see on the monitor, okay? Adenosine is an interesting, drug to push, 100%. You just have to make sure you're educating them. It's not an alone drug where you're just gonna willy-nilly push this. You're inviting the physician, a charge nurse, defibrillator, pads on, okay, to be the most prepared. Questions about this? No? You guys good? I love that video. That poor lady, she's sad. Okay, let's talk about atropine. Atropine is kind of a weird standalone drug, to be honest. Like, I was trying to figure out, I'm like, does it qualify to be an antiarrhythmic? But it's not really an antiarrhythmic. But I need you to understand what you use it for, okay? So take a moment, okay? What kind of patient needs atropine? What is the expected results, okay? And then are there any nursing considerations that you need to do? Please know that adenosine, right? Adenosine and atropine are both IV push only. You do not have an atropine drip. So to try to make, I'm also a picture person, okay? So atropine, I'm kind of giving the answers away. But this is how I remember atropine. That's right. Organophosphate poisoning. It's a new one, guys. I've never even heard of that. That's great. I love it.
It's pesticides,
Oh,
pesticide poisoning.
from ingestion? Or
Ingestion
exposure.
or exposure.
Wow. That's great. I love that. So I feel like it's probably more like in a region, well, I don't know, I guess ingestion might not be the same. Probably exposure is what I would guess.
Like, Yeah, we had a patient, pest control guy, his tank kind of exploded on him.
That would be some severe exposure.
Yeah.
Yeah.
So, and then the atropine basically just reverses the organophosphate.
Oh, sure. That makes perfect sense, yes. It's just like we use, there's another poisoning. I think it's antifreeze, and we use glucagon, I think. But it reverses it, essentially.
Yeah.
It's like some chemical reaction. Okay, so let's talk about this. So, atropine. So, who is the type of patient that we use? I see a lot of this, right? Symptomatic bradycardia. What the heck does symptomatic bradycardia mean? What does it mean to be symptomatic?
You can tell.
Without looking at the hormone.
Okay. Totally. So someone that's symptomatic, right? So Scarlett, what were you saying?
You might be like dizzy, lethargic, even fainted.
Totally. Yes, absolutely. So someone that is dizzy, someone that's lightheaded, maybe they had a syncopal episode. Okay. So again, someone that isn't tolerating that low rate. Okay. So bradycardia, right, is anything less than 60. Okay, anything less than 60. And when you're symptomatic, it means you could be feeling those things. If you took a blood pressure, right, cycled a blood pressure, they more than likely would be hypotensive. Okay, hypotensive. They might be pale. They might be confused. Okay, so again, make it make sense, right? So we remember our hemodynamic calculation, right? I mean, why would I not go back to that? So if you're bradycardic and your heart rate's in the 40s, for example, and let's say your stroke volume's okay, but you've lost that component of your cardiac output, what is that going to look like, right? It's going to affect your cardiac output, which makes sense, right? That makes sense. Why you're dizzy, why you're lightheaded. Your perfusion isn't great. Does that make sense? Okay. So again, symptomatic bradycardia, you're not tolerating that. Okay. What about the athlete? My uncle is a marathoner, and his heart rate was in the 30s, and he had to go to the hospital for something I can't remember. I think he had like knee surgery or something, hence the marathoner, right? And like the nurse was freaking out that he was in the 30s.
His heart's strong enough to be
Sure, it can be, right? It can absolutely be it, but he's an athlete. And then look at it, right? His heart is very healthy, and it doesn't need to beat that fast. So look at your patient, right? Make it make sense. Just because it's a low heart rate, is he tolerating it, right? I went in, I was like, hey, Uncle Paul, how you doing? Great, I'm great. I'm gonna have my surgery today, it's fine. His heart rate was like 39, okay? The nurse was also freaking out, and I was like, let's like go blood pressure. Blood pressure is great. It was like 125/80, like totally a normal blood pressure, okay? So he was alert and oriented, his color looked great, he wasn't faint, he wasn't lightheaded, he just was tolerating that. So this person, he would not need atropine. He's fine being that bradycardic, okay? What do you say?
He's not symptomatic.
He's not symptomatic, okay? So you're only giving atropine when someone is bradycardic and they're symptomatic, okay? That's the key thing, symptomatic. So, if giving someone atropine, what's my expected result? What should happen? Increase heart rate. So instead of a heart rate of 40, hopefully I see 60. And then clinically, Scarlett, what's better? What are they better? You said they were lightheaded, dizzy.
They'll feel like they snapped out of like a day's problem.
Totally, absolutely, yes. They're alert and oriented. They're not feeling lightheaded. They can get up and walk around with falling down, okay? So make sure you understand what that expected result is. Yes, the heart rate's going to go up, but they are going to look better, okay? They're going to look better. Interestingly enough, atropine is an anticholinergic, okay? That's like the class. I'm not gonna ask you that, okay? But I just need you to understand that it could affect, because it's an anticholinergic, you could see your patient having like, what is it called? Urinary retention, okay? Urinary retention. Anything that an anticholinergic can produce could affect it, okay?
Felt anxious.
Huh? What'd you say?
Felt anxious.
Afterwards? I guess it's possible. Does the anticholinergics make people anxious?
I guess it's not a
Okay. I mean, it could. People can feel anxiety. Absolutely. Medications do weird things. So that could absolutely be. So urinary retention. Let's see what else. What else? Excessive cell. I think it's the opposite, isn't it? Atropine. It decreases your secretions, right? Anticholinergic decreases it, so people get dry mouth. They need to like suck on candies and stuff. Again, that's if you're giving atropine a lot, right? You may not have these kinds of long-term results, but just be aware that it's an anticholinergic and it is associated with these kinds of situations, okay? Questions about this? Okay. Just know that if you're treating symptomatic bradycardia with atropine, we're gonna probably need something else, right? If they sustain it, and it worked, that's great, but it might not be a long-term solution is what I'm saying, okay? All right, let's talk about mannitol. So mannitol, when would you use this drug? What's the expected results? And what are the nursing considerations with it? So also, side note while you're doing that, atropine, right? There's a lot of A's that we talk about. Don't get them confused. Atropine, I drew an arrow, okay, right? Because we're increasing the heart rate. It's just like a little pro tip to remember. Because people, you can get adenosine, atropine, and amiodarone all confused, and you don't want that. Only three people know mannitol. That's it?
Oh, let me put more, let me put more.
All right, friends, let's talk about this. So look at that description right there. I love it. Okay, so what is mannitol, right? Someone very astutely did all this, wrote this whole thing out. I love it. It's excellent. Okay, so what it does is that it draws the free water from the brain, right, into the circulation. Why we want to do it, right? Why someone would use this drug is someone that has increased cerebral edema, right? Extra water on the brain, okay? So extra water on the brain. Also, they have increased intracranial pressure. Professor Bluer, we haven't gone over neuro. You're saying words that I don't know, and this is upsetting to me. Don't be upset, okay? Just know that cerebral edema, right? Cerebral edema is swelling on the brain, okay? And if you think about swelling, right? Any type of swelling that you have can increase pressure, okay? Where is the swelling happening? Where is the increased pressure? Intracranial, okay? You don't need to know all the facets yet, but know that mannitol, we'll certainly use it a lot when we get to our neuro section, but mannitol helps treat, okay, that cerebral edema, which is thus increasing your intracranial pressure, okay? So we can expect, right? We can expect the down and dirty is it to decrease cerebral edema, right? To decrease ICP. It's not gonna be that easy though. I never make things that easy, right? Although there's no trickery, I'm gonna ask you, how's your patient gonna look? You gave mannitol, right? You gave mannitol, so how's your patient going to look? How do you know it worked?
Their headache went away, urine output.
What do you say?
Urine output.
Close. I mean, not close. Be careful. That's what I meant to say. Be careful. So urine output is not going to tell you that it worked. Okay? I love your thinking. It is an osmotic diuretic. You should have urine output. Absolutely. But how you know the drug worked is how you look at your patient and you say, okay, did their ICP decrease? Did their cerebral edema? Well, Professor Bloor, I can't just look at someone and know that. Heck yeah, you can. Do an assessment, right?
Are there eyes bulging out?
Yes. Well, I mean, that would be terrible. But is their neuro exam better? Okay? Is their neuro exam better? Okay? So yes, you absolutely are going to have increased urine output. That is a given. But we don't know if it worked. The expected result is their neuro exam is better. Okay? So let's say they had ICP, you know, really increased 25. Let's say if you had an intracranial pressure monitoring system, right? And let's say the cerebral edema, their neuro assessment was terrible, right? They were obtunded, very hard to arouse. They were confused when you did arouse them. Their pupils were unequal. Like, let's just make the exam terrible, okay? So you give the mannitol. Yes, they're gonna pee out all extra fluid. I love it. Because the fluid, the free water is coming from their brain. But how we know it worked is their neuro exam is better. Their ICP is lower, and they are alert and oriented. Their pupils are normal. They're equal reactive, okay? So their neuro exam has gotten better. They have better cerebral perfusion, okay? So with mannitol, something that we need to understand, yes, it's an osmotic diuretic. You should expect some urine output, but the best way to know that it worked is that cerebral perfusion has increased. Their neuro assessment has gotten better, okay? Now, if someone has renal failure, is this an appropriate drug to give them?
No, because
Why?
it increases the risk for that. Because
Okay.
all that fluid's going into the body and then putting pressure.
There's nowhere to go, right? If they have renal failure. So it doesn't preclude people with renal failure. We just need to coordinate with dialysis. They need to come and get run at the same time. Because all that extra free water from the brain is gonna go into the system to be peed out, but these people aren't peeing. So now where is it going, right? So you can give it to someone with renal failure. You just need to understand that they need to be run for dialysis at the same time, okay? Because we need to get that extra fluid out. Now, with any diuretic you're giving, okay, with any diuretic, are you worried about any specific labs?
Electrolytes.
Electrolytes, yes, absolutely. You want to check the electrolytes 100%. Specifically what?
Potassium.
Potassium.
Sodium.
Yes, exactly, okay? So you want to make sure you're doing your labs before and after to see if you just messed up all your electrolytes, which you probably did, okay? Now, sometimes you have to also be careful when you have acute heart failure, okay, with this extra fluid, especially if their kidneys are not working. Maybe they're not totally a dialysis patient. They don't have renal failure and they don't get dialysis Monday, Wednesday, Friday. But someone that has heart failure and they get mannitol, they could run into some problems because they can't move the fluid accurately. Does that make sense? So it could worsen your heart failure and cause increased pulmonary edema. Does that make sense? Okay, so just be aware of that. Questions about mannitol? Isn't Pharm fun? Are you guys having the most fun right now? I'm having the most fun. You're like, oh my gosh, T-minus 25 minutes, I can get out of here. Take my nap, watch Disney Plus, work on my whatever you want to do, okay? We're almost done, guys. We got this. Okay, so vasodilators. We haven't really talked about some of the vasodilators yet. And you better believe that one that I'm going to ask all the questions about, and we're going to talk about it next week too. You will constantly see questions about this particular vasodilator, whether it in multiple routes, sublingual, yeah, nitroglycerin, yeah, sublingual, a patch, IV drip. Okay guys, let's talk about this. So a couple people put drugs. I wouldn't say atropine's a vasodilator. So I don't know if I would. What? Atropine? I don't think it doesn't work on the vasculature though. It just works on the heart, like the heart, like so it's like almost like a heart rate situation. So let's just ignore the atropine. But I see a lot of like descriptions, which is great, right? So a vasodilator, right? So vaso is the vasculature, and then dilate, right, is widen it, right? Dilate it, make it bigger, okay? So great, finally, love it. Nitroglycerin and nitroprusside. Those are the two main ones, and then I also see narcotapine, okay? Also known as cardine.
Sorry, it wasn't in the question to name the specific ones.
No, I love it. I love it. Narcotapine is something that I would love for people to know. It is not added in your soft chalk. I should have added it because now they've added it to the curriculum. So narcotapine is definitely a calcium channel blocker that you will see, and oftentimes you'll see it when someone is in a hypertensive crisis, okay? So the other ones that you see, the vasodilators, more specifically, is nitroprusside and nitroglycerin, okay? Now let's focus on nitroglycerin for a second, okay? Nitroglycerin you're going to see and hear a lot, especially next week when we get to ACS, acute coronary syndrome, okay? So what would be the number one question I want to ask my patient before I give them any sort of nitro? Whether I'm doing sublingual or starting IV. No, you're on the right track, absolutely. So erectile dysfunction, okay? So any sort of erectile dysfunction medication, right? Interestingly enough, people that also have pulmonary hypertension are on those types of drugs. So anybody know, yes, I know everybody else talks about Viagra. What's another name for it? Cialis, okay. What's another type of drug that you might see that people will be on? Either for pulmonary hypertension or ED. Anybody know? Anybody heard of sildenafil? That's very common, okay, sildenafil. So you need to ask your patients if they're on any sort of drugs like this. Why is that important? What?
It could have
Also vasoactive.
bad interaction.
Yes, it can have a bad interaction. Anybody know what could happen? If your patient took sildenafil, for example, in the morning, and now they're having an MI and you're giving them nitro, what could happen?
Their blood pressure.
It'll take their blood
Absolutely.
pressure.
Good job. Tank their blood pressure, you guys. Profound hypotension. So oftentimes we don't give people that have taken that type of medication nitro yet. We have to wait for it to be out of their system because it can cause profound hypotension. So that's absolutely one of the questions that you have to ask them, okay? Are you gonna see that on all of your tests? You better believe it, okay? That is a huge, huge question, assessment question to ask, okay? Now, nitroglycerin is a pretty legit drug, right? It's a strong vasodilator, but it also dilates your coronary arteries. That's why we love it for ACS. We love it when people have MIs, we put them on nitroglycerin, okay? It also decreases your preload. So it's like a trifecta kind of situation, okay? So nitroglycerin is perfect, we love it. You need to make sure that you are checking their blood pressure, okay? Because we know that it's gonna lower their blood pressure, okay? So if you give your patient specifically nitroglycerin because they are having an MI, right? They're having an MI and you start a drip, for example. How do I know that the nitroglycerin is working? What would be my expected result? What do you think? Chest pain, yes, ding, ding, ding. Their chest pain would subside, okay? Why are they having chest pain? Probably due to the cardiac ischemia. You just dilated their coronary arteries and helped all the blood flow to go. So their chest pain should be better. That's an expected result. That's how you should know that it worked, okay? Now, let's dive into nitroprusside. I'll be honest, I hate nitroprusside. I hate it so much. Unfortunately, in the CV world, it's a very common drug. It's interesting because I also feel like it goes in waves. So when I first became a nurse, I saw it a lot, even though it was a general ICU that I worked in. And then I went through this time where I didn't see it at all. And now, all of a sudden, in the last couple of years, especially when I float up to CV, they use it a lot, okay? It's actually a pretty old drug, to be honest. You have to protect it from light. It's light sensitive, okay? And know that why we're giving someone nitroprusside, oftentimes it's that hypertensive crisis, okay? It's acute pulmonary edema or maybe some sort of CHF exacerbation, okay? It's going to be that potent vasodilator that decreases that afterload, okay? It's gonna vasodilate. It cannot be stopped abruptly, okay? It cannot be stopped abruptly. So this is one of those drips that you don't wanna run dry, okay? I'm sure you've seen it at the bedside, right? You have all these drips going and the bag's running dry. You have to order it from pharmacy. Pharmacy's taking a long time. You don't wanna just turn it off because you can have significant rebound hypertension, okay, and seizures. I'll never forget when I had it when I was in Flag. Again, I was a new nurse, and the charge nurse came around and we were talking about my patients, and she was great. Her name was Susie. I loved her. I wanted to be here, like when I was a fresh nurse. And she's like, so you got nitroprusside, huh? And I was like, yeah, I do. And she's like, all right, well, just know that they can bottom out just like that. And I was like, what do you mean bottom out? And she's like, well, you know, you could be fine 1 minute and all of a sudden your blood pressure will be in the toilet. And I was like, what? I did not know that. It freaked me out so much that when I was charting, I kept doing this to the monitor because I was so freaked out that it was gonna 1 minute bottom out. Do know, okay, that can happen, it's unlikely, but you really don't want it just to stop abruptly. Whether you're turning it off at whatever dose, you haven't titrated it down, okay, or it's run dry because you didn't refill the bag in time, okay? Because we don't want that rebound hypertension where all of a sudden they're in the systolic in the 230s and they're gonna seize and stroke out, okay? Does that make sense? Again, light sensitive, okay? You have to protect it from it. It won't work if it is exposed to the light. And then it can cause some cyanide toxicity. So you just have to make sure that you're aware of that when you're on it for a long time. It's not funny. I don't know why I'm laughing.
It is a little funny.
Questions about vasodilators. What's the number one thing you have to ask someone when they're on nitro? Whether it's sublingual, you're doing IV, whatever.
Do you take any other blood pressure medication?
And
Have they taken any sexually
specifically,
enhanced drugs?
okay, ED or pulmonary hypertension medication. Okay,
What if they don't wanna
sildenafil.
tell you?
Still ask what?
They don't wanna tell you. and all
Well,
of a
that,
sudden
I mean, that's a
blood-
bummer. They're gonna.
You can let them know, I need to know for sure, or you could die.
I mean, I would say it maybe a little bit better, but you would tell them, just say, if, you know, this is what could happen, and we're trying to avoid that. You know, profound hypotension, your blood pressure could get so low that you could arrest, okay? Just cardiac arrest. Does that make sense? And then that just tells you how important it is. Okay. Okay, my most favorite thing in the whole world to talk about, okay? My most favorite thing in the whole world to talk about is vasopressors, okay? Do you guys want to just talk about it, or do you want to do the collaborative board? Your choice. We're running out of time. You want to just talk about it? Okay. So vasopressors are my most favorite thing in the entire world to talk about because I love them so much. They are my bread and butter in the ICU, okay? So there's 4 of them. Okay, there's 4 of them that I want you to be aware of, okay? So, let's see. There is the first line. The first one that you usually start would be Levophed or norepinephrine, okay? You are starting this when someone's MAP is low, okay? Not 65. They are hypotensive. It is a vasoconstrictor, okay? Something to make note of is that before you start your vasopressors, in order for them to work most effectively, you need to make sure that your tank is filled. Okay? You need to make sure that your tank is filled. Especially when we have someone in septic shock or hypovolemic shock, you need to be filling that tank or your pressors aren't going to work. Okay? So fill the tank and then you can utilize your vasopressors. So Levophed or norepinephrine is the first one you start. The second one that you start, and again, I'm just telling you what it's like at the bedside and what I want you to know for my test, okay? Vasopressin. Vasopressin is the next one. Vasopressin and Levophed are best friends. They synergistically work beautifully together, okay? Vasopressin is a hormone, okay? It's an antidiuretic hormone. So it helps to hold on to fluid. It's great. That's why it works so great, okay? We love it. ADH, antidiuretic hormone, vasopressin. So, we start vasopressin. I'm still not getting an adequate MAP. I need some more help. The third one would be phenylephrine or neosynephrine. Okay? That one is one that we use pretty often, but oftentimes it's added, right? You add it when you still are not an adequate MAP. Okay? Same thing, vasopressor. Now, all of these that I'm talking about are vesicants. What the heck does a vesicant mean? What?
It irritates the vessels.
Yes, absolutely. So it irritates the vessels, okay? So you need to be infusing these through a central line, okay? A big lumen central line, okay? Any sort of vesicant needs to be going through a central line, okay? So vasopressors are vesicants. They can irritate the vein. If they extravasate, if they go into your tissue, it can cause tissue necrosis. You don't want that. Okay, you don't want that. I've seen someone lose their arm because an IV infiltrated, we were running it peripherally, and Levophed went into their tissue, and they had to have an amputation because it was so bad. So that's why it's super important to try to infuse it in the central line. It doesn't stop you. So let's say you admit a patient, pressure super low, you're starting all the pressors. Well, they don't have a central line. I can't start them. No. You're going to start them through a peripheral, but you need to be talking to the physician and saying, yo, I need a central line in here, okay, for long-term use. Okay, you're going to start it and hopefully have them in a peripheral, but in your brain, you know I need a central line. They're a vesicant, okay? The last one is epinephrine. That's the big daddy, okay? Epinephrine is the big daddy. That's the biggest one, okay? Epinephrine is a vasopressor that you can give as a continuous infusion or an IV push. Why I say it's the Big Daddy, it's because you give it when someone's dead, okay? You give it when someone is dead. So epinephrine is an important one. What it does is it shunts blood from your peripheral circulation to your central circulation, okay? To your heart and your brain, okay? Epi is super important like that. Yes, we wait to start it, okay? It also has some inotropic effects where it helps your contraction, okay? So you might see it for that, but again, the fourth line, it's the Big Daddy of vasopressors, okay? How do I know that it worked? How do I know that these worked? My map is better, yes, absolutely. My map is better. So central line, my map is better, that's how I know it worked, okay? Now, know with side effects, okay, it's a vesicant, you want it in the central line, but know that it's going to vasoconstrict, okay? Especially when someone has a very low blood pressure and you have multiple vasopressors going, it vasoconstricts to the most important organs, right? Heart and brain. So what happens to this? What happens to your fingers and toes? They can turn black, yeah, 100%. It's not funny. I don't know why I'm laughing. I'm sorry. It's late in the day. So they can turn black, right? Absolutely. Okay, so just know that it's doing their job. It is. It's very unfortunate. People will get very freaked out. But it's one of those things, life over limb, right? I know that sounds harsh and terrible, but it's life over limb. You might lose some fingers and toes, but you're alive, okay? It's because we're shunting blood to all the most important areas because we're constricting the tiny vessels distally, okay? Okay, I think I covered everything with that. Let's move on. Okay, this is pretty important. I do want to spend some time on this, okay? So this is your RAS. I know that you guys saw this, okay? I know your brain is dead. We're almost done, I promise. We probably won't do the last two sides. Maybe we'll finish those next week. I haven't decided. But they are good for studying. So this is your RAS, okay? This is how you're titrating your sedatives, okay? This is how you're titrating your sedatives. Joint Commission, the people that accredit us at the hospital, are very big on the RAS, okay? My management, very big on the RAS. They'll come find you if you don't chart it, okay? So this is how you are charting, this is how you're supporting your titrations, okay? In a perfect world, you want your intubated patient 0, alert and calm. Is that real life? Absolutely not. Does that ever happen? Very rare, to be totally honest. But oftentimes you have a range, it's 0 to -2 light sedation, okay? What that means is that when I go in and I say, hey, Mr. Smith, can you open your eyes? Less than 10 seconds takes him to open his eyes, okay? But then when I leave him alone, he goes back to sleep. That's in a perfect world, okay? Most people that are intubated find it very uncomfortable. I don't know if anybody's been intubated in here. I personally have not, but I would hate it, right? I'd probably be gagging on it and trying to rip it out. So those are these people up here, agitated. This supports the ability to go up on your drip, okay? You need to make sure you're understanding how you can support your titration up, okay? Now, there's a couple, right? We're just gonna talk about this, okay? There's a couple of sedatives that are for intubation people only, okay? So propofol, you must have a definitive airway to be given propofol, okay? Propofol, it's the white one. Michael Jackson was illegally using it. Not a great idea, right? Everybody remember that? Not great. He shouldn't have been giving it like IV push. No wonder he died. I mean, it's very sad, but I'm not surprised, right? Obviously that was years ago, and now that I know what it is, I'm like, what was that doctor thinking? But anyways, so propofol, intubated people, okay? Midazolam or Versed drip, intubated people, okay? These are all sedatives, right? They make people sleepy, okay? They make people sleepy. Now, non-intubated, someone that's awake, okay? Like our patient today, right? Report 500 years ago, remember? The guy that drank all the vodka that's going through withdrawals. Something that he could get to chill him out, because now he's like withdrawing like nobody's business. He doesn't know where he's ANO times 0. He's trying to punch people. He's trying to get out of bed. He's like kicking people. You're gonna have to 4-point restrain him. he could earn himself a Precedex or dexatomidine drip. Okay, you can run that drip with not someone that's not intubated. It's beautiful. It chills them out beautifully. Okay, someone's not tolerating their BiPAP. Grandma hates it. She keeps ripping it off. You ask for a Precedex drip, dexatomidine. You do not need a definitive airway to give it. Okay, it's just a nice drip to chill everybody out. Okay, oftentimes it's a transitional drip that you can start when you're trying to extubate someone. Okay, so propofol, yay, we love it. It has a short half-life. You have to be monitoring lipids or triglycerides with it because it's lipid philic, like it's lipid based. Okay, so you have to do your triglycerides. People are like obsessed with it, and I was like, oh my gosh, it's not that big of a deal. Their triglycerides are 300, not that much, but anyways, you do have to get your triglycerides. We do monitor that, but it's short half-life. That's the cool thing. Okay, patient or doctor comes in, says, hey, I want a neuro exam on your patient. You can titrate your drip either down or maybe off. I'll go start it off though. And you can get a neuro assessment pretty quickly. Very short half-life, which is lovely, okay? Easy on, easy off, that's what I say. Conversely, Versed lasts for a long time, okay? Lasts for a long time. It loves adipose tissue. So if you have someone that has a lot of adipose tissue, right, BMI is very high, then it can hold on to Versed for a long time, okay? The other negative to Versed or any sort of benzodiazepine, it contributes to ICU delirium, okay? So when you're studying, I need you to go over and understand which strip you're gonna use for which person, okay? Propofol should not be an IV push done with nursing. Doctors can push propofol, we cannot, per Arizona State Board, okay? You can draw it up and hand it to a physician, but they're doing that, okay? Know that the dosage changes when you do an IV push. Someone pushed a lot of propofol recently, too much, okay? Know that a side effect of this is hypotension. It can cause hypotension, any of these, okay? Versed less so than propofol, okay? Let's see, dexatomidine or Precedex easier for me to say, I'll be honest, can cause bradycardia. That's one side effect to be aware of, okay? Because oftentimes you'll see a decrease in their rate, okay? Oftentimes people expect that, so unless they're less than 40s, we just let it ride. Again, up to the physician, okay? But no, that is a significant side effect that can happen. Questions about this? Wait, what? Propofol and Versed as a drip. You can give IV pushes of Versed to anybody. You want to make sure that you don't like give them too much that they can't breathe, but you can give an IV push to someone, and it's not going to necessarily depress their respiratory rate. Yes.
What is the genetic name for
Midazolam.
Professor, and
Yes.
you said you were gonna build a sort of guide.
Yep.
Will you be listing the medications for
Yes.
you to know?
Yes. Essentially, that's what the guide is. It's like a list of them, so you know, okay? But this is how you should be studying, you guys. This is how you should be studying. That list that I made at the very front of the Nearpod, you should do that for every drug, okay? Because the question is going to say, your patient's giving nitroglycerin, how do you know that it worked? Your answer should be a decrease in chest pain, okay? Yes, we know that it's going to lower their blood pressure. We know that. It's a vasodilator. But how I know it worked is I don't have any chest pain anymore, okay? Does that make sense? Okay. It's not trickery, I promise. It's not trickery, it's straightforward. I'm sad that we can't do the last two slides, but it's okay. They're just applications. Maybe we'll start with that next one next time. Okay, so before you guys go, thank you very much. I know this is a lot of information, okay? So cardiac, next week is gonna be, you think today was hard? It's gonna be a doozy next week, okay? So bring your extra coffee, your Celsius, whatever. That's not the one with alcohol, right? You shouldn't bring alcohol to school. But the one that is the energy drink to help you get through that, okay? So my recommendation, this is serious, okay? Cardiac rhythms are hard, okay? They're hard. You will have strips on your exam, and you have to identify them, okay? But that's not even the worst part. The worst part is you have to identify it in your brain, and then the question is gonna say, what do you do about it? So you're gonna need to know the intervention. Again, you guys, block 4, the ante is up, okay? So, there is a cardiac rhythm. I will email it to you, okay? When we used to have 7 weeks, we would have 1 day just to learn all the rhythms. We don't have that luxury anymore, sadly. So this is my significant other who is an expert in cardiology, an expert. And he teaches cardiac